Another cause of congenital hemolytic anemia is that caused by enzyme deficiencies, and the best example and the commonest in our country is glucose 6-phosphate dehydrogenase deficiency. It is the most important disease of hexose monophosphate pathway and is responsible for 2 clinical syndromes: episodic hemolytic anemia induced by infections, certain drugs, and favipiravir, and spontaneous chronic non-spherocytic hemolytic anemia. It has the advantage of resistance to falciparum malaria in heterozygous female. The deficiency is caused by inheritance of any of a large number of abnormal alleles of the gene responsible for the synthesis of G6PD protein. Some of these mutations cause episodic, others cause chronic hemolysis. Milder disease is associated with a mutation near the amino terminus of the G6PD molecule, and chronic non-spherocytic hemolytic anemia is associated with a mutation clustered near the carboxyl terminus. The normal enzyme found in most population is G6PD B+. Another normal seen in African American population is G6PD A+. More than 100 distinct enzyme variants of G6PD are associated with a wide variety of hemolytic disease. The disease is an X-linked recessive. It means the male are affected while the female are carrier. In our country, female can manifest the disease because, according to the Loyen hypothesis, as you know, female has 2 X chromosomes. One contains the normal gene and the other the abnormal gene in a ratio of 50% or 1:1. If the X chromosome contains the abnormal gene will be in excess of that carrying the normal gene, the female will manifest the disease. Homozygous female and heterozygous male have a level less than 5% of the enzyme level, while heterozygous female has intermediate enzyme activity. The genetic changes result from single amino acid substitution, causing alteration in the enzyme activity. This slide shows the red cell metabolism, where it takes its energy from either anaerobic glycolysis and the hexose monophosphate shunt. 85 to 90% of the energy is through the anaerobic glycolysis, which utilize adenosine triphosphate that maintain the integrity and deformability of the red cell membrane. 10 to 15% of the energy is through the G6PD, which protect the through the hexose monophosphate shunt, which utilize G6PD. It protects the self-hydryl containing protein of the red cell, including hemoglobin, enzyme, and membrane against oxidant stress. This protection done by the enzyme G6PD through maintenance of glutathione in a reduced state. If G6PD is deficient, the enzyme is unable to maintain adequate level of reduced glutathione in the red cell, called hemolysis. There are 2 types of hemolysis: intravascular, which is dominant with acute hemolytic attack and is due to disturbance of the red cell membrane through peroxidation of red cell membrane lipid, while the extravascular, mainly seen in the chronic non-spherocytic hemolytic anemia and is caused by hemoglobin denaturation with Heinz body formation. This will affect the physiologic property of the red cell, which will be destroyed by the reticuloendothelial system. The first manifestation of G6PD deficiency is that of acute hemolytic anemia, which may be either caused by drug or by favipiravir. It is mainly seen in the acute hemolysis, mainly seen in Mediterranean groups who are G6PD B-. It is usually severe because the enzyme activity of homozygous female or hemizygous male is less than 5% of normal. There is no symptoms unless the individual is exposed to oxidant stress, including therapeutic drugs such as sulfonamide, antimalarial, antipyretic, and naphthoquinone, ketoacidosis, henna, naphthalene, and lastly, sabine. The degree of hemolysis vary with the incenting agent, the amount ingested, and the severity of enzyme deficiency. This table shows different drugs that are responsible for inducing hemolysis in G6PD deficient individual, and usually we supply each patient with a list of these medication in order to be avoided when they are ill. They may be antibacterial, such as sulfonamide, ciprofloxacin, nalidixic acid, trimethoprim, sulfamethoxazole, antimalarial, antihelminthics, chemicals such as vitamin K analog, chemicals like benzene, and illness like diabetic ketoacidosis, hepatitis, and sepsis. The second manifestation, also acute hemolysis, is that of favism, which results from fava beans ingestion. This results from oxidative products derived from two glycosidic compounds, the vicine and convicine, which are hydrolyzed to dificine and isouramine, ultimately producing hydrogen peroxide and other reactive oxygen product. Favism is thought to be more frequently seen in G6PD B- variant individual, and the onset usually within 24 to 48 hours of exposure. So, the clinical manifestation for both drug-induced hemolysis and for fava beans usually occur within 24 to 48 hours after exposure to a offending drug or ingesting fava bean. And usually there is fever, malaise, jaundice, dark-colored Coca-Cola-like urine causing hemoglobinuria, low hemoglobin which may be life-threatening, and high reticulocyte with the presence of Heinz body in the red cell. The third manifestation is that of neonatal jaundice, which may be so severe that it requires exchange transfusion and may cause kernicterus. It can be induced by drugs given to the mother or to the baby during the first 3 to 4 weeks of life, infection, or acidosis. It is more common in Orientals and Greeks. The fourth manifestation is that of chronic non-spherocytic hemolytic anemia, which is seen in Northern European countries in a few families. Usually there is persistent anemia exaggerated by infection or drugs. In G6PD A- variant, the condition is usually mild. It is seen in male American of African descent in whom the G6PD activity is 5 to 15% of normal. Here, when hemolysis occurs, the aged red cell destroyed, and the associated reticulocytosis produce a compensated hemolytic process in which the blood hemoglobin only slightly decreased despite continued exposure to the offending agent. The lab findings show low hemoglobin and hematocrit, saturation of haptoglobin, free hemoglobin appear in plasma and urine, causing dark-colored urine, supravital stain of the red cell reveal Heinz body, and blood film reveal fragmented red cell with polychromasia representing reticulocytosis, which is usually 5 to 15%. In this slide, you can see presence of Heinz body. These spots within the red cell, they are inclusion body, and here the apple bitten appearance typical of red cell fragmentation in G6PD individual. The diagnosis is usually established by enzymatic assay done 1 to 3 months after an attack using spectrophotometric test or fluoro spot test, which measure the generation of NAD pH to detect reduced G6PD activity in the red cell. In deficient individual, the activity will be less than 10% of normal. Treatment: when there is acute hemolysis, blood transfusion is given. Chronic non-spherocytic cases require folic acid supplementation. Prevention by screening early in the neonatal period, and those who are proved to have G6PD should avoid contact with the precipitating factor. It was found that 10-misporphyrin, which is a synthetic analog of heme oxygenase, can strongly suppress the production of bilirubin, and so it will eliminate the need for phototherapy and prevent severe hyperbilirubinemia, so it can be given in the neonatal period. The usual dose of aspirin and trimethoprim sulfamethoxazole do not cause clinical relevant hemolysis in the A- variety, but when aspirin is given in a dose of 60 to 100 mg per kg per day to treat rheumatic fever, hemolysis may occur and may be severe. If hemolysis occurs, we can continue with the treatment but transfuse the child, although recovery is the rule when the oxidant agent is